This is the Hall Institute Forum. My name is Michael Rickards, and we're talking today about the question of health care. David, let me ask you a question which is, I think, of importance. First, in terms of people not being insured, President Bush said it's not a matter of concern. Those people can use the emergency room. Why is that not a good answer?
Because it's not practical. The bottom line is nursing, emergency room care is absolutely the most expensive care you can get. And when I was asked this one time, I said, in the president's example, you bring a young boy in and give him a nebulizer so he can breathe because he has asthma, but you can't give him a little inhaler that'll make him be able to breathe forever. You know, it's just not a good way to do it. In addition to which, the cost of that care is killing our hospitals. So I think the president knows now that he misspoke. That was a bad answer.
Now, you've spoken to Rich about the question of New Jersey's plan and the bill introduced by Senator Vitale.
Yep.
It struck me it had a lot of similarities to the bill in Massachusetts that Governor Romney signed when he was up there. Are there differences that are significant? Sure.
I can take you through them pretty quickly. The similarities are that it has an individual mandate, that it sweeps in as many that are in entitlements as it can to get federal match. It also requires a Section 125, which allows people to buy their health benefits with pre-tax dollars if their employer doesn't cover them. But that's where the similarities end. In the how it differs is, number one, they created a thing called the connector that took people into matched you up, like a super broker that matched you up with, if you were uninsured, with some sort of insurance that you could afford. The problem with that was it was taking you in one at a time, so Michael would get covered and Rich would get covered and Dave would get covered instead of all three of us together where we got a spread of risk. And so expectedly the cost went through the ceiling. So it got to be very, very expensive. The second thing that's different is that they did individual policies. We have one state-sponsored plan. So there's only one plan, state-sponsored, which sweeps everybody who doesn't have health insurance into that coverage. So we get those 700,000 lives that we're pulling in are coming into one place. So you get the law of large numbers, you get better spread of risk. And finally, in Massachusetts, they had what's called an employer mandate. It says if you don't provide coverage to your employees, then you've got to pay a penalty. In Massachusetts, it was $295 per employee per year. Well, that was cheaper than 1 month's premium. That wasn't a smart move, and they learned it wasn't a smart move. We don't have an employer mandate. We believe that employers want to give coverage to their employees. The problem is affordability, and we're trying to address that. So most of the coverage in New Jersey right now is employer-based coverage. So, and there's no requirement that they do it. So we do not have an employer mandate at all. We're probably one of the only proposals in health reform that does not have an employer mandate. But I'll point out that every major think tank, liberal and conservative, would tell you that pay-to-play mandates just don't work. So that's a huge difference between us and Massachusetts.
We've gone through all of these different discussions about medical care, and we have different options. As you've identified, Massachusetts has one. Now we're doing one, looking at one in New Jersey. There are other states, as you know, that are going through the same thing. Why don't we just have universal health care coverage like the rest of the civilized industrial world?
Well, I think that would be a wonderful solution. The problem is that it's proved very resistant to getting it done. Think of what you'd need if one of the candidates got elected and got it done at a federal level. You'd need a candidate who was committed to universal health care. You need a Congress that's committed to universal health care. You need 50 states to agree to go along with that particular process. And the financial implications to insurance companies, which really were active in killing the first Hillary Clinton plan, to hospitals are huge. And so the implications are just huge. I think it's much better to prove the concept, the laboratory of democracy, if you will, at the state level. And then I would love it if a concept that worked would go up to the national level. That's how the DRG system that we have in Medicare was done. It was a demonstration project in the state of New Jersey when I was Deputy Commissioner of Health. We used DRGs to set rates before Medicare did. And it became the national system. It still is being used to this day. And we proved the concept in New Jersey. And I believe firmly we're going to prove the concept in health reform as well.
Do healthcare issues vary significantly from state to state? I was wondering, like, say, here in New Jersey, do we have issues that are unique to us, and maybe that's a barrier to having universal health care
Sure,
nationwide?
lots of issues. We have more mandates, more requirements for what insurers have to cover in this state than any other state in the nation.
Does that drive up the cost?
Yeah. Sure. Our healthcare costs are number one in the nation, too. So there's great variance. What doctors can be licensed, how much practice can a nurse do? These are all state issues. They're all regulated at the state. That's when I said to Michael's question, what's the problem with the federal government? They don't regulate many of the things that you need to make the system work. They're state regulated. They're controlled at the state level. And it's very easy sometimes for politicians who don't want to get into an issue as complicated as healthcare to say it's a federal issue. That's a simplistic answer because 90% of healthcare issues are state issues. And you would have to get the governor of Illinois to agree to allow his nurses to practice at such and such a level or allow his doctors to do such and such. And that's just not the way the system has been established. Ultimately, it may.
Now, Sherry Glidd, professor of public health at Columbia University, came and did 3-part series for us at the Hall Institute, which is still on our website. And I think it's probably 3 of the best pieces that have been done on the New Jersey medical care system, comparing us to a couple of other states, indicating where our costs are higher, where our costs are lower, that sort of thing. One of the things that struck me, though, is the whole question of prior conditions. Under New Jersey law, I think you cannot deny people health care for prior conditions.
That's right.
But you can deny them home care. Why the distinction? In fact, we want to force more people to be cared for at home rather than in hospitals. But in New Jersey, that prior condition is permitted. Why is that?
Well, the pre-existing condition is the largest overall impediment, regardless of age, to getting health care. If you're sick, you can't get the care. And so it becomes a vicious circle. You can't get in. I think what happens is the home care provision, which I think most people support, hasn't evolved at the time that the laws were struck. So I think that will change. I know that the AARP is pushing hard for that. I think that law will change, just as that the law hasn't changed in that regard. One comment, though, as a result of your 3, if you're people who watch this, we looked at Sherry Glidd's stuff on your material on your website, and we actually went into New York at Columbia to meet with her. She was very helpful in helping us with the economics of the Vitale plan.
Good. Well,
she was outstanding.
The whole Institute's always glad to play a benevolent role in,
in
public policy.
You had a real role in this particular
Very
one.
good. It's good to hear. That is our time, and we thank you very much for being here, for discussing what is probably, I think, the most important domestic policy issue that we're going to be dealing with, and we hope we'll be able to get you back once Congress deals with the issue once again. Thank you very much, David.
Thank
Richard?
you.
Okay.
Thank you.